low dose inhaled corticosteroid. Moderate, a medium dose ICS all by itself, or we can go with a low dose ICS and a long acting beta agonist. Step 4, severe, medium dose ICS and a LABA. And severe step 5, we take them up to a high dose inhaled steroid and a LABA, and we would consider Xolair for those patients. On all of these, of course, it's monitor peak flows also. Okay. This is just to show also on number step 6, if they're that bad, we're also going to add oral corticosteroids. And then we'll get patients off that as soon as possible also. Steroids are, I run into patients who are reluctant to take inhaled steroids because of the bad reputation they have, and I understand that, except it is much more dangerous for a patient, an asthmatic patient, not to be on oral steroids than it is for them to take them. With inhaled steroids, less than 10% of that medication gets absorbed systemically. So they're really much safer to take than the oral steroids, and like I said, it's dangerous not to be on them.
Can I ask a question?
Absolutely.
Is the nasal Flonase, is that considered inhaled steroid?
No, it's going to work just topically in the nares. That's a good question. That would not work for an inhaled steroid for the lung disease. Okay. Our goal, of course, is control and controlling the symptoms that we've got, many of those that were on the chart. We want normal to near normal PFTs. We don't want them using their SABA very often. Normal activity levels, and this is something that has changed. Decades ago, severe asthmatic, especially children, were told that they needed to sit out all the time and not participate in a lot of activities. But for many years now, instead, the attitude is if you're not able to do what you want to do as an asthmatic, you're not on enough controller medications. We don't want ED visits, obviously, and with an asthma action plan, we can help prevent those, and hopefully the best meds without bad side effects. So the asthma management is similar, I'm sure, to many other chronic diseases that you've looked at. There's a patient's part and our part. The great thing about asthma is there really is a chance for it to be controlled very well. That's not unrealistic. Okay. The asthma action plans look too busy, actually, to put on a slide, but what it looks like, it's got the basic information on the patient with their controller meds and their rescue medications, what their personal best peak expiratory flow is. And the way they get that is once a patient's stable, we have them measure their peak flow twice a day, morning and late afternoon, for a couple weeks. And the highest number there is that person's personal best. It may or may not be as high as what's predicted for their age and gender. But that's their personal best, and we're going to gauge everything on the action plan off of that. Their primary care provider information, reminder of triggers, and then under each zone is what symptoms you might see and then what you should do for that. So our green zone, everything's looking good, 80% or better of personal best peak flows, and take regular controller meds. Yellow zone, we're at a 50 to 80% of personal best on the flows, and we're taking our SABA as needed. Usually increase controller meds, start oral steroids, avoid triggers. The action plan is written out by a physician, so whatever medications they're on, and he knows, she knows that they need to start or step up. A danger zone is if they're less than 50% of the personal best, and they need to be seen immediately, and taking the SABA for relief as they get there. Okay. What to do for exacerbations: use the action plan and remove the irritants, and monitor response to treatment is important also, and let the primary care provider know if there's a change in the response to treatment. What can happen is that the SABA use held them over for a few hours, and now it's only helping for maybe 5 or 10 minutes, and that's a huge red flag. Okay, what not to do, these are some of the home management techniques that have not been proven to be helpful at all. Pursed-lip breathing we'll get into a little bit on the COPD. It might help them calm down, but it doesn't help with lung function. Okay. These are some of the risk factors for asthma-related death. So severe exacerbations, if they end up being in and out of the ER, like the lady in the thing, if they're using up SABA canisters all the time, but actually inhaling the medicine and still bad. And if they're not on top of how bad their obstruction is or their psychiatric disease. Okay, so the big thing about asthma again is actually it's education, education, education. We try and go over all of the things on the asthma action plan and the control of triggers every time we meet with an asthmatic. So a few things which your favorite asthmatic won't tell you. There may actually be a few triggers on the job. Look at all the dust or the smoke in that picture. I'm supposed to use a spacer? Inhaled steroids are always an issue. I had a patient tell me she didn't believe in taking medication. She just wanted to work through this. It's like, sweetheart, you're in the ER. That is not working for you. People don't want to offend somebody by telling them they can't smoke in their house. What peak flow meter? Don't worry, her asthma is always mild, always. That was me. Got in trouble one time when I thought, I won't react to this. And the cat did not get a new home. In fact, it sleeps on the asthmatic's face at night. No kidding. This was told to me by an asthmatic. No, she's supposed to stay on my pillow, but usually when I wake up, she's on my face. All right. COPD, yes?
With an asthma flare with a long-term infection, what prednisone dose are you used?
What kind of what dose?
What kind of prednisone dose?
You know, it really, that is a good question. I haven't been on something for a while. They'll usually start, God, a real low dose would be maybe like a 10 milligrams and taper it down. You know, it really depends on the asthmatics, and if they're already on inhaled steroids, then they're probably going to need a bigger punch with the oral steroids. So that's a good question. On COPD, this is what I think of in scaling COPD because it's such a huge term, but we will narrow it down a bit here. Objectives are the same, except we'll look at exacerbations. Asthma has the EPR3 guidelines, COPD has the GOLD guidelines, and this is all available on the internet, and this is everything outlined for treatment, the pathology, primary care recommendations, it's all very good information. COPD prevalence, over 125,000 deaths a year. Actually, it seems like that should be a little bit higher. Fourth cause of death in the United States and the leading cause of death worldwide, almost exclusively due to exposure to smoke or smoking. 6 leading causes of death, only COPD has been increasing. The others are heart disease, cancer, stroke, accidents, and diabetes. And they're all either holding their own or decreasing, but COPD continues to increase. Some of the definitions here, what stands out is it is a largely preventable, at least the aspect of smoking, and it's characterized by airflow limitation that is not fully reversible as opposed to asthma. And the COPDers are definitely going to react to any noxious particles or gases they breathe, and the disease is progressive. So what we're looking at is usually an onset in midlife, usually a long smoking history, characteristic dyspnea on exertion. Okay. What I'm going to narrow it down to, COPD is an umbrella term that actually can be used for any obstructive disease in the lungs. Most of the time people are talking about chronic bronchitis and emphysema. Technically, asthma is a COPD also, except since it's reversible, it's usually not lumped in with those. There are a few other diseases like cystic fibrosis and bronchiectasis that aren't usually referred to when people talk about COPD. But it is an umbrella term. It's not a definitive disease. What it is, chronic bronchitis and emphysema are kind of two different ends of the spectrum, and your average COPDer kind of has a little bit of each one of them. So chronic bronchitis, the technical definition for this, daily productive cough for at least 3 months of the year for 2 consecutive years. Okay. Inflammation and secretions provide the obstructive component of chronic bronchitis. The body responds to these changes by decreasing ventilation and increasing cardiac output. And this makes for a VQ mismatch. VQ means ventilation perfusion mismatch that results in rapid circulation, but in a poorly ventilated lung, leading to hypoxemia and polycythemia. The hypoxemia also ends up leading to pulmonary artery vasoconstriction and right heart failure. What it looks like on our patients is usually the blue bloaters, okay? If a person's on the chronic bronchitis end of the spectrum, he'll tend to be of normal weight or overweight, coughs frequently, brings up a lot of sputum. On chest exams, the breath sounds are usually junky, sound like a Maytag washer, crackles, rhonchi, maybe even some wheezes in there. Emphysema is defined by the destruction of the airways distal to the terminal bronchial. Terminal bronchial is just the last bronchi on the way to the alveoli. It's the last one is what it's talking about. The physiology involves a gradual destruction of those alveoli septa and the pulmonary capillary bed, and this leads to decreased ability to oxygenate the blood. So then the body compensates with a lower cardiac output and hyperventilation. So it's the opposite VQ mismatch, low circulation and high ventilation. The rest of the body suffers from tissue hypoxia, and that leads to muscle wasting. Okay? So these patients are what we call our pink puffers, thin with muscle wasting, wide barrel-shaped chests. They always feel short of breath. When they cough, they don't produce a lot of sputum like the chronic bronchitis patient. On chest exams, a person's breath sounds will be distant but relatively clear. In fact, sometimes they're so diminished, I'll check my stethoscope and make sure, because you're not hearing any air movement at all. This is showing the breakdown of the alveolar walls, and you can see why there's such a total lack of elastic recoil in the emphysemic patients, and a lack of gas exchange. These are the steps that often can lead to the right heart failure in these patients. Okay, differential diagnosis. CHF is, like I said, it's going to have crackles also. The PFT is going to show airflow restriction, not obstruction, so it's pretty easy to rule out. And TB we can find out with the chest x-ray. The diagnostic tools, again, with COPD, PFTs are very, very useful, and it's going to show us not just if they have COPD, but how severe it is. Chest x-ray usually shows the air trapping. We draw an arterial blood gas to show what degree of hypoxemia they have and if the CO2 retention is chronic. If they retain CO2 chronically, they're going to have an elevated bicarb because the body is going to compensate so that the pH is always normal. We'll also look at if there's no smoking history or exposure to smoke, we'll look at alpha-1 antitrypsin deficiency. And this is a rare disorder that actually causes the same emphysema as smoking, but it's hereditary. So it could be somebody who's never smoked in their life, and they can end up actually dying of emphysema the same as a heavy smoker. The management program covers everything, especially managing stable COPD to try and prevent the exacerbations. So our management goals are going to vary with different severity depending on if they're, whoops, that was a little fast, if they're at the mild end of the spectrum or if they're more toward end-stage COPD. A lot of this is prevention. common symptoms mild. Symptoms come and go. They might not even be aware of it yet. They just think that that junky